All right, so part 2 of chapter 3, looking at cytochrome P450 on page 57. Cytochrome P450 enzyme inhibitors increase the concentrations of substrate drugs. Drugs that are cytochrome enzyme inhibitors decrease enzyme function and the ability to metabolize compounds. Drugs that are substrates for the same cytochrome enzyme will have a decreased rate of drug metabolism and an increased serum drug level. In some cases, less drug will be lost to first pass metabolism. Enzyme inhibition is fast. Effects are seen within a few days and will end quickly when the inhibitor is discontinued. With prodrugs, inhibitors and inducers have an opposite effect on drug levels. With an inhibitor, there are less functional enzymes to convert the prodrug and the concentration of the active drug decreases. See clopidogrel example in the common prodrug study tip gal on the previous page. The FDA labels enzyme inhibitors as strong, moderate, or weak based on the effect of metabolism of substrate drugs. The study tip gal below describes cytochrome inhibitors that are commonly involved in drug interactions. For most, the interaction occurs because the drug listed is a moderate or strong cytochrome 3A4 inhibitor. For others, for example, amiodarone, interactions occur due to the drug's ability to inhibit multiple cytochrome enzymes, for example, 3A4, 2C9, 1A2. So we can look at, there's a chart here, and it's looking at common cytochrome inhibitors involved in drug interactions. So we're looking at grapefruit. We're looking at protease inhibitors, especially ritonavir, but many protease inhibitors are potent inhibitors. We're looking at azole antifungals like fluconazole, itraconazole, ketoconazole, posaconazole, voriconazole, and we're looking at cyclosporin, macrolides like clarithromycin and erythromycin, but not azithromycin. We're looking at amiodarone. We're also looking at calcium channel blockers, the non-dihydropyridine ones, so the diltiazem and verapamil type. They came up with an acronym for this chart of G Heart Pac-Man. So grapefruit, heart, protease inhibitors, azole antifungals, cyclosporin, macrolides, amiodarone, and non-dihydropyridine calcium channel blockers. Then there's some notes here. Effect on substrates, so decreased metabolism, increased serum levels, and clinical effects. Inhibitors equals increased effects or levels, toxicities, effect on prodrugs, decreased conversion to the active drug, and decreased serum levels and clinical effects. how do you recognize the problem? So perform therapeutic drug monitoring, monitor for therapeutic effect, look for ADRs, look for toxicities, possible actions, decrease dose of substrate, use a prodrug, use alternate drug to avoid combination. So here's a case scenario, toxicity with an ACE inhibitor. We have a 76-year-old male presenting to the pharmacy with a voriconazole prescription to treat aspergillosis. His medication profile includes betaxolol, 1 drop OU twice a day, simvastatin 40 milligrams at bedtime, hydrochlorothiazide 25 milligrams every morning. Recognizing the problem. So voriconazole is a strong cytochrome 3A4 inhibitor. Simvastatin is a major cytochrome 3A4 substrate. Voriconazole will increase the simvastatin level, increasing risk of muscle toxicity and rhabdomyolysis. So what would we do? So the combination of voriconazole and simvastatin would be contraindicated. So how would we handle it? We would ensure that the drugs are not used together. We might recommend an alternative statin, like changing over to Crestor. Okay. Now we're looking at cytochrome enzyme inducers. So before we were looking at inhibitors, now we're looking at cytochrome enzyme inducers. So cytochrome enzyme inducers, we will see a decrease in the concentration of the substrate drug. Before we were seeing an increase in the concentration of the substrate drug with the inhibitor. All right, so here we go. Cytochrome enzyme inducers will decrease the concentration. Drugs that are cytochrome enzyme inducers increase the enzyme production or activity. Drugs that are substrates for the same cytochrome enzyme will have an increased rate of drug metabolism and thereby a decreased serum drug level. In some cases, more drug will be lost to first-pass metabolism. The inducers can cause therapeutic failure, which will be the lower drug level. So with an induction, there are more enzymes that will be catalyzing this conversion of the prodrug, and the concentration of the active drug in this scenario will be increased. Similar to inhibitors, the FDA labels enzyme inducers as strong, moderate, and weak based on the effect on metabolism of substrate drugs. So we're going to check out study tip gal below. She, describes cytochrome inducers that are commonly involved in drug interactions. For most interactions, for most, the interaction occurs because the drug listed is a moderate or strong cytochrome 3A4 inducer, and or it induces multiple cytochrome enzymes, for example, rifampin. So let's take a look. There's we have listed phenytoin, smoking, phenobarbital, oxcarbazepine, rifampin, carbamazepine, St. John's wort. We have an acronym of PORCS. So phenytoin, smoking, PS, and then phenobarbital, oxcarbazepine, rifampin, POR, and then CS, carbamazepine, St. John's wort. So what's the effect on the substrate again? It increases the metabolism. So then what happens to the serum levels? They become decreased. So clinical effect, therapeutic effect is decreased. Again, inducers, decreased. We have decreased effects in decreased therapeutic levels. What happens to prodrugs? So in this scenario, we're going to have increased conversion to the active drug. So with the prodrugs here, we're actually going to have increased serum levels and clinical effects. How do you recognize this problem with cytochrome enzyme inducers? So you have to perform therapeutic drug monitoring. You have to monitor for therapeutic effects. What do you do? What type of actions do you take? So you may have to increase the dose of your substrate medication unless it's a prodrug. You may have to use an alternate drug to avoid combinations. Let's take a look at a case study. This case study will be showing a subtherapeutic level with an inducer. There's a 34-year-old female with a mechanical mitral valve. She has been taking warfarin chronically to prevent thrombosis. So she takes warfarin 5 milligrams by mouth daily. Her INR range for the last 6 months is typically 2.6 to 3.1. Her INR goal is 2.5 to 3.5. So she is within her goal. She was admitted for infective endocarditis and started on gentamicin, ceftriaxone, rifampin, and vanco. Alright, so what's the problem? Well, rifampin is an inducer of P-glycoprotein, cytochrome 2C9, 3A4, 1A2, and 2C19. Warfarin is metabolized by cytochrome 2C9 in a major way. Also, it's metabolized by 1A2, 2C19, and 3A4. So what's going to happen? So if we induce warfarin, we're going to have subtherapeutic levels. So what should we do? Okay, according to this case study, what did they do? Well, they wanted to monitor her INR more frequently. They also wanted to increase her warfarin dose as needed based on her INR. So instead of taking 5 milligrams daily, it's very likely that because of these different medications she's on, especially rifampin, that she's going to need to take more warfarin than 5 milligrams daily. So based on her blood levels, they're going to have to increase her warfarin dose. Alright. Time check. Keep going. So lag time for enzyme induction. Induction most often requires additional enzyme production, which takes time. The full effect on drug levels may not be seen for up to 4 weeks. So when the inducer is stopped, it could take 2 to 4 weeks for the induction effects to actually completely disappear. The excess enzymes will degrade based on their half-lives. All right, gut excretion by drug transporters. So P-glycoprotein efflux pumps, permeability glycoprotein, so P-glycoprotein efflux pumps or transporters are located in many tissue membranes where they protect against foreign substances by moving them out of the critical areas. The term efflux means to flow out. The P-glycoprotein pumps in the cell membranes of the GI tract will transport drugs and their metabolites out of the body by pumping them into the gut, where they can be excreted into the stool. So when a drug blocks or inhibits P-glycoprotein, a drug that is a P-glycoprotein substrate will have increased absorption. Less drug is pumped into the gut and the substrate drug level will increase. There are other transporters in the other parts of the body that are not described here, including efflux pumps that cause resistance by pumping chemotherapeutics out of cancer cells, and the organic ion transporter OATP1B13, which pumps drugs and other compounds from the blood to the liver. There is overlap among the enzymes and transporters that protect the body from perceived toxins, including drugs. Many drugs, which are substrates, inhibitors, or inducers of P-glycoprotein, have the same effect on cytochrome P450 enzymes. The table below lists many P-glycoprotein substrates, inducers, and inhibitors. A chart of common cytochrome P450 substrates, inducers, and inhibitors can be found at the end of the chapter. Alright, so here's our chart. We have P-glycoprotein, common substrates, inducers, and inhibitors. So common substrates for P-glycoprotein include anticoagulants, so we're thinking apixaban, rivaroxaban, dapigatran. We're looking at cardiovascular drugs, digoxin, carvedilol, verapamil, ranolazine, diltiazem. We're also having substrates of cyclosporins, sirolimus, and tacrolimus, which are immunosuppressants used in transplant. We also have P-glycoprotein, common substrates used in, let's see, all other areas. So we're just going to list them out. So we're going to look at like colchicine, we're going to look at saxagliptin, raltegravir, posaconazole, dolutegravir, let's even throw in some sofosbuvir, dasabuvir. Looks like we have a whole bunch of substrates and they're just thrown in there. All right, in terms of inducers for P-glycoprotein, we're just going to have to memorize the chart. We have carbamazepine, we have dexamethasone, phenobarbital, phenytoin, rifampin, St. John's wort, we know that one, St. John's wort is everywhere, and taprenavir. And in terms of P-glycoprotein common substrate inhibitors, we're thinking first anti-infectives, clarithromycin, itraconazole, posaconazole, cardiovascular, amiodarone, carvedilol, diltiazem, dronedarone, verapamil, quinidine. And then we're just going to lump everything else under other. So we're going to throw out cyclosporin is a substrate and an inhibitor. We're going to put ritonavir under inhibitor. Yep, that's not under both. We are going to also add ticagrelor as an inhibitor. Yep, that one is not a substrate. Alright, so we're going to come back to the chart on page 59, and then we're going to look at enterohepatic recycling. So after a drug has been metabolized in the liver, it can be transported through the bile back to the gut. From the gut, the drug can be reabsorbed primarily in the small intestine, where most drugs are absorbed, enter into the portal veins, and travel back to the liver. The recycling of an already metabolized drug is called enterohepatic recycling, which increases the duration of action of many drugs, including some antibiotics, some NSAIDs, and the cholesterol-lowering drug ezetimibe. Common drug interactions. Drug interactions are an important part of pharmacy practice. This chapter will cover drug interactions that involve major drug classes. So, for example, central nervous system depressants or drugs with specific properties like QT prolonging drugs. Other important drug interactions involving specific drugs, warfarin, lithium, theophylline, and more are discussed in depth in their respective chapters. So we can look at anticoagulation, we can review asthma, and we can also review psych. So the major categories of drug interactions discussed in the tables following. We're just going to look briefly again at cardio, inhibitors that will increase substrate drugs, inducers that will decrease substrate drugs, drugs with additive risk, and this is just to review some concepts. So we have, let's see, how many pages of charts? We have 1, 2, 3, 4, 5, 6, 7 pages of charts to review. All right, and so that will be pages 60 through 66, and I can review that independently. And this will close out part 2 of chapter 3.